Well, let's get started. We are off to our next topic, which hopefully we'll get through today, although there's a lot of material, and we will use our familiar strategy, depression, looking at it, behavior, from the standpoint of what was going on in your brain seconds before, the neurochemistry, the circuitry, hormones over previous days to weeks, brain structure over previous months to years, and then looking at early life features of risk of depression, which is all about psychological stress, and then what's going on with your genes, and finally evolution of. So we start off with this, with my considering this to be like one of the most important classes in this course, and the one that, like, unfortunately is probably most pertinent to a lot of people in here. Depression. Major clinical depression. Right off the bat, we start off with this semantic problem in that we all get depressed. Something crummy happens, you get a bad grade on something, somebody is ignoring you, and you feel kind of crummy and you don't feel like doing much and you're sort of unmotivated and like you're sleeping long hours and after a few days you get better. No, this is what all of us go through. This is everyday depression, and our first challenge here is I'll be using the word depression throughout in a very different sense. Depression, major depression, a biological disorder, and it's one in which you don't just feel crummy and low energy or whatever for a few days afterward, weeks, months, years, its characteristic being that it's incapacitating. So we will look at the biology and the psychology that intertwine today. We won't be talking anything about bipolar disorder, which is a separate species, and only a little bit on anxiety in passing. Okay, before getting started with behavior, quick demographics. Why is this an important topic? Because major depression, and I'll be using that interchangeably with depression. I don't mean depression in the everyday sense. Major depression is a catastrophe. Best estimates are 15% of humans on Earth will at some point have a major depression that makes it impossible for them to function. It is astonishing. We will get to some of the details of it insofar as women are twice as likely as men to suffer from major depression, and we will get to whether that's really what's going on or if there could be something else. The World Health Organization used to rank depression as the number 4 cause of disability, lost work, lost functioning on the planet. It is now listed at number 2. And perhaps the most alarming thing about depression is a very clear epidemiological literature showing that over the last half century or more, with each passing decade, there's a higher and higher incidence of depression. Oh, obviously people know how to look for it, confounds all of that. Careful epidemiological surveys that control for that show that essentially in every industrialized country, rates of depression have been rising over half century, decades beyond that. And what is that about? We get one hint into that by seeing that with each passing decade, the number of kids and adolescents, teenagers who fall into a major depression of a type where they have now joined the lifelong cadre of people at risk for the depression to return, that those numbers are getting bigger. With each generation, more and more young people are being recruited into the army of people dealing with this disease. Okay, so as we get to it, the point I'm going to hammer over and over and over and get until you're sick of it is this is a disease. Amid everybody getting depressed, everybody gets depressed, and like a lot of how we come out the other end of it is we like pull ourselves together and we count our blessings and we think about the good things in our lives and we like have some gumption and stop babying ourselves and all of, and there is this terrible temptation among lots of people who have never been touched by major depression to view it as a disorder of self-indulgence and lack of backbone, of come on, show some gumption to get out of this. And what we'll be seeing today is depression is as real of a biological disorder as is diabetes. And you don't sit down a diabetic and say, oh, what's with this insulin stuff? Stop babying yourself. Come on, you could do without it. Depression is a real biological disorder. As we will see, it is actually a whole family of them. So we start off with behaviors, the symptoms, and a lot of these will look like everyday depression stuff multiplied a gazillion times. Some of them will be completely unique. First off, the defining symptom of depression, anhedonia. Hedonism, the pursuit of pleasure, anhedonia, the inability to feel pleasure. Something wonderful happens, it doesn't register. You have nothing you're looking forward to. You're not interested in trying to achieve it. Ooh, not only loss of pleasure, loss of anticipation, loss of motivation to do what's needed to get those rewards. You better bet right now that you've got a neurotransmitter in mind that is implicated in this. So, defining, it is a disease, as was said, of malignant sadness, and one piece of it is inability to feel pleasure. Psychomotor retardation. Everything is exhausting. It's exhausting to do, to think, to get anything done. You can't get out of bed because why bother? And it just feels as if there's a thick quilt suffocating you. You need to do your laundry, but you haven't done it in weeks because you don't know where the basket is to put the stuff in. And where's the change? And oh no, I got to go get some laundry detergent. And it's all too much and you go back to bed. This sort of involution, this hibernation of psychomotor retardation. Next, depression forever was classified as a disease of abnormal feelings, sadness, absent of pleasure, and a whole branch of work in this field, CBT, cognitive behavioral therapy, mostly pioneered by this guy named Aaron Beck. Beck sort of shifting that depression is just as much a disease of abnormal cognition. One feature of it, memory problems. People with major long-term depression get memory problems. Is that because the neurobiology of memory isn't working so hot in them? We will see some reasons to think that. Or is it because they're so unmotivated they're not even trying on these tests? That's part of it also. And next, a really central feature of the whole cognitive school of looking at depression is the notion that depression is a disease of cognitive distortions, of a trauma that happened back when you were young, you have now turned into, it will always go badly, it will always turn out poorly for me, where you have overgeneralized and distorted this into being your worldview. Things are bad, they're just going to get worse, I deserve it, there's nothing that could be done, a cognitive distortion. And this is shown with all sorts of studies, like you ask people to spell out words and you say the word pain, and people with depression write P-A-I-N much more often than P-A-N-E or die, D-Y-E or D-I. It's just an unconscious distortive sense running through everything. Interesting elaboration on that, though, that should start to feel a little bit familiar. Amid people with major depression being distortive, oh, this is the rest of I will always fail, I will never be loved, just distorting some event into being just a global picture of your destiny. People with major depression are pretty good at assessing the likelihood of outcomes of things for other people. When you look at regular old folk without depression, they are pathologically optimistic, which is to say that people tend to way overestimate the likelihood of a good outcome. People with depression are far more accurate, giving rise to the soundbite in the field of depression. People with depression may be sadder but wiser. and you see something that should sound like when you get a lesion to your dorsolateral prefrontal cortex or something. You've got somebody with a depression, and they give incredibly good, realistic advice to somebody else about their problem. But when it gets close to home and it's emotionally loaded, that's where the distortions come in. That's where you see people way overestimating likelihood of bad outcomes, inevitability of. Third cognitive feature, rumination. You've got the sad thoughts, you've got the grief-filled thoughts, you've got the guilt-filled thoughts, you've got these bad thoughts, and they don't stop. They just go on and on and on. And translating that into the neurobiology, you can guess where we're heading. You're not able to stop them. You ruminate. You are stuck in it. We will see how this really is central to a lot about the disease. Obviously, depression, self-injury, mutilation, cutting, suicidal ideation is not synonymous with depression. Cutting is not synonymous with depression, but there's heavy overlap, and these are disastrously dangerous possibilities. Just to give you some statistics about suicidality in depression, women are more likely to attempt suicide than are men. Men are more likely to succeed. The most common picture of somebody who commits suicide is a white guy over 65 years of age, unemployed or underemployed, little social support, substance abuse problem or a drinking problem, and access to a gun. That's the most common profile. Okay, so I'm making this argument here. Depression, major league depression, is not just, oh, come on, pull yourself together. It's a real biological disease. Part of what makes that point is people with major depression, their bodies work differently, what are termed vegetative symptoms. As we will see, people with depression have elevated levels of glucocorticoids in their bloodstream, dramatic foreshadowing that stress is going to be playing a role. The whole structure, sleep architecture is disrupted. You have less of the restorative slow wave sleep. You have this phenomenon of early morning awakening. You wake up at 5 in the morning, you are completely exhausted, but you are awake, and you've been doing that for months and months. Early morning awakening as one of the hot spots. Appetite usually going in the direction of people undereating. Okay, so the vegetative symptoms, this is real biology. You're asleep, and your brain function, your sleep architecture is working differently. This is not, oh, come on, show some willpower. Finally, there's all sorts of subtypes of depression with different of these features at the forefront and such. And there's another feature of depression with lots of people. It cycles. Cyclic ones, you get a bad one for 2 months, it goes away for 6 months, comes back again. There's another version of seasonal affective disorders, SADS. Better bet they celebrated after coming up with that. SADS, where you get depression in winter months with short light exposure. And that's one of those where something tragic happens to someone in June and they feel depressed and it's a drag and they pull themselves out of it out the other end, and nothing is going wrong in January. Yet once again, like every one of the last 10 years, the person falls into a major depression to the point of having to be hospitalized. So cyclicity, we're not just dealing with one disease, we're dealing with a bunch of them, we're dealing with disease. So what we shift to now is, so what's going on in the brain when you are feeling anhedonic or vegetative or any of these things? What's going on in the seconds before? What's the neurochemistry of depression? And here we return to the synapse, and just a reminder, some of the dynamics of neurotransmitter comes out and responds to an action potential, gets dumped, binds to the receptor, does its thing to this neuron, and it comes floating off the receptor, and then you have your two housekeeping options. Either you could take advantage of a reuptake pump that will take the neurotransmitter, put it back, and reuse it, or there's an enzyme that will break it down and flush it down the drain. Okay, here's the important point. So you have a disease, a neuropsychiatric disease, whatever, and you throw in a drug which blocks this reuptake pump. What's the consequence of that going to be? The neurotransmitter sticks around longer in the synapse and hits the receptor a second time, a third time, a fourth time. Suppose doing that makes somebody's illness worse by increasing the amount of neurotransmitter in there. What's your conclusion? The core of this disease is too much of this neurotransmitter. On the other hand, if when you block this reuptake pump, the person's symptoms get better, when more neurotransmitter is sticking around there, what's your conclusion? This is a disease of too little of that neurotransmitter. And in the exact same way, if you throw in a drug which blocks the breakdown so that the stuff sticks around longer, same exact logic as to how to conclude whether or not we got a problem here of too much of a neurotransmitter or too little. And overwhelmingly, the one that everyone pays attention to is serotonin. Serotonin, we've heard that in a number of guises so far. Serotonin has some interesting relevant effects in the frontal cortex. The overwhelming evidence in depression is there's too little serotonin. And what is that mostly shown by what at the time was the most revolutionary antidepressants the universe had ever seen, SSRIs, selective serotonin reuptake inhibitors. Selective, it's only working on serotonin. Selective serotonin, reuptake inhibitors, blocking the reuptake. And thus, if serotonin sticks around longer and hits the receptor a second, a third, a zillionth time, and the person starts feeling better, ooh, I bet you there was too little serotonin in the first place. The serotonin hypothesis. And that is the leading evidence for it these days. And historically now, there's been two problems with it, which is when serotonin first swept in, everyone said, that's it, serotonin. Depression equals too little serotonin. That explains everything. And we'll see, no, there's lots of other stuff going on. And more recently, the problem is lots of people noticing that, oh, serotonin doesn't cure everyone. Maybe it really isn't all that important. There's a revisionism going on with serotonin right now, which I'm unimpressed by. In the majority of cases, implication is that there's too little serotonin. So that's great. There's problems with it though. By the way, the most common SSRI is Prozac, which lots of you will be familiar with. But again, what they all do is selectively block the reuptake, inhibit the reuptake of serotonin, sticks around longer, you feel better. I bet there wasn't enough in the first place. Now, out of that, though, comes a bit of a problem that we're going to see applies to all the neurotransmitters we're about to look at. Next relevant neurotransmitter, norepinephrine. Norepinephrine, sympathetic nervous system, lots of places in your brain. And going through the same logic there, drugs discovered in the early 1960s, which blocked norepinephrine reuptake or blocked the degradation of norepinephrine. Norepinephrine sticks around longer. It made some of the symptoms better. The norepinephrine hypothesis, there's too little norepinephrine. And that was the first neurochemical hypothesis about depression in the early 1960s, and it completely dominated the field until the SSRIs came in and everybody learned how to spell serotonin. Norepinephrine is part of it as well, and we will see how. And of course, the third of our big three, you've got to be jumping out of your seats now shouting dopamine. Dopamine is relevant as well. And drugs that boost up dopamine signaling have antidepressant effects. And it turns out some of these drugs that only work on the serotonin system, selective serotonin reuptake inhibitors, or only work on the norepinephrine system, are in fact not all that clean, that they have some spillover into the dopamine realm. Okay, so the same logic, short depletion of dopamine. So too little serotonin, too little norepinephrine, too little dopamine. In the last decade or so, a fourth neurotransmitter has come onto the scene, glutamate. Glutamate, we haven't talked much about glutamate. It's a highly excitatory neurotransmitter, and people have found that if you block glutamate signaling to one of its receptors, the NMDA receptor, that could have some antidepressant effects. And thus, a drug came online, was approved, I don't know, half a dozen years ago. It was the first new class of antidepressants approved in decades and decades, a drug which blocks those receptors. A drug called ketamine. Ketamine is now all over the place as an antidepressant, and it blocks these receptors, and people feel better. And what does that have to suggest to you? There's an excess of glutamate going on there. So this helps to begin to resolve one challenge in the field. You throw in an SSRI and 2 hours later something different is happening here. You throw in one of those drugs that hit norepinephrine or dopamine, and hours, minutes, you're already changing stuff here. But in all three of those cases, the person doesn't start to feel better until many days, weeks or so. These drugs do what they do over the course of minutes to hours, but they're not effective for days to weeks. And that has produced all sorts of agonizing models where maybe the problem is that you're upregulating or downregulating the number of receptors or the autoreceptors back there. All of that, but a big clinical challenge throughout has been you throw these drugs in, and if they're going to work, could take days, could take weeks, may never work. The thing that was revolutionary about ketamine is it breaks the back of the depression within hours, within a couple of days. It is very, very fast acting. Okay, so a couple of other players in there that we'll just touch on briefly. Inflammation. Chronic inflammation in the brain increases the odds of depression. And people know inflammation is doing all sorts of interesting things to serotonin and norepinephrine, all of that. There's a bunch of viruses that increase the likelihood of depression. It's looking like COVID is among them when you get long-haul COVID. Gut microbiome is relevant to all of that. But what we most importantly have here is just this picture of three neurotransmitters that have been traditionally implicated, shortages of them, as the meds show, the drug treatments show, and this new player suggesting an excess of glutamate. So how do you put those pieces together? Let's get insanely reductive and simplifying here right now. How do these pieces fit together? Serotonin is about the rumination. Serotonin, when you throw in an SSRI like Prozac, the first symptom relief that somebody gets is the rumination stops. They stop having the inability, just the bad thoughts going over and over and over again. Supporting that view, very interestingly, you can use SSRIs for people with obsessive compulsive disorder. OCD, what are elements of that? Obsessive, repetitive, ruminating thoughts that you forgot to lock the door, and SSRIs boosting up serotonin signaling makes the sad, ruminative thoughts of depression less oppressive, and it makes the repetitive worries, ritualistic rumination of OCD better as well. Okay, so that's the serotonin part of the story. Dopamine, yes, you guessed it. The dopamine part has something to do with the anhedonia, and what we're going to see in a bit is glutamate comes into that as well. Norepinephrine. Norepinephrine, what is it about? It's mostly about the psychomotor retardation. There's a part of the brain that I don't think I've ever mentioned, and we're going to hear it now once, called the locus coeruleus, and that is relevant to arousal and activation, and norepinephrine does something to it and a shortage there, and you got it is exhausting to get out of bed. It is simply too tiring. You got the psychomotor stuff. Now, norepinephrine and psychomotor brings up one of the most tragic features of major depression, which is, when is it's most dangerous? When is somebody most likely to harm themselves? And every psychiatric facility knows the most dangerous time in terms of suicidality or self-injury is when somebody is finally beginning to come out of the severe depression, and paradoxically, they're getting enough energy there to finally effectively damage themselves. What's going on in your brain seconds before, not in terms of the neurochemistry, but in terms of the brain circuits. And 20 years ago, what you would get now is a list of parts of the brain that have been implicated in depression. What there's enough information about now is the circuits that are involved. As things have gotten even fancier with brain imaging, you can see in the circuit, this activates first, which then activates these two, which then activates this one. You can see the flow of information in these circuits. So, 3 circuits are worth us paying attention to. The first one we know all about, in your sleep. This is the dopamine world of pleasure. Anticipation and motivation, ventral tegmentum to nucleus accumbens and on, mesolimbic and mesocortical. So, this is the world we know. And what is most likely going on during depression, what most of the imaging studies suggest and the neurochemical studies suggest, is that during depression, there's overactivation of the amygdala. We've already heard something about this. Amygdala, fear, aggression, male sexual arousal, hyper-responsive to sad stimuli. Insofar as the amygdala is about fear, if you're depressed, the scariest thing on earth is something that's going to make you even sadder. The amygdala tending to be overactive in depression and transcending the fear aspects, just negative affect, distress, all of that. What does an overactive amygdala tend to do? It tends to inhibit this dopamine pathway. It does it in part directly. It does it also by stimulating the anterior cingulate cortex, and we know something about what it does, and that does it by stimulating, here's a brain area we haven't mentioned before, here's the one time, called the lateral habenula. And when activated, it also inhibits the dopamine system. What's interesting about this? First off, the anterior cingulate, we already have seen anterior cingulate is about empathy, is about confusing psychic pain with real pain. The ACC tends to be overactive in people with depression. Depression is a disease of incapacitation by psychic pain. It is the disease of feeling the pains of the world to a paralyzing extent, and it plays out here by stimulating this lateral habenula too much, and this is where glutamate comes in. People have figured this out recently. Okay, so ACC. So you've got the ACC, and if its problem is in depression, thanks to the amygdala doing its thing there, if the problem is it's overactive and psychic pain and you're feeling the pains of the world and all of that, and suppose it's there to like an absolutely crippling extent, I've just come up with a clever idea here. Here's how we could treat depression. You go in with a big old knife and you cut the projection coming from the ACC to here, and the rest of the brain, in fact. Whoa, that'll cure your depression. Brilliant. What a great intervention. This is actually done. This is done in cases of severe depression where no meds have worked, no combination, a number of different things you could do, electroconvulsive therapy, something called deep brain stimulation. None of those work, and the absolutely desperate, like last gasp Hail Mary thing is to go in and do a surgical procedure called a cingulotomy, a cingulum bundle cut. And what have you done here? You've made it impossible for the ACC to have its sad thoughts and convince the rest of the brain to go along with it. And this is done, I don't know, rarely 20, 30 cases a year, but this is really a desperate measure. Okay, you may ask, so if you're wiping this out and you're wiping the ability for abstract pain, if you cut this pathway, are you also doing something with the ability for abstract pleasure? Yeah, probably. Whoa, great philosophy paper. Is it better to have pain if it means we have pleasure as well as one without the other? Yeah, again, good philosophy papers. If somebody is coming up for the cingulotomy, they have been in the state hospital with every med thrown at them, and they're still trying to slit their wrists once every few months or so. There are no abstract pleasures that may be compromised by this surgery. Okay, so we have this. One last piece of evidence for the dopamine involvement, i.e., I forgot to say it a few minutes ago, there is now a very useful technique where you stick an electrode down into the dopaminergic system and you stimulate there. You stimulate for more dopamine release. It is called deep brain stimulation, and you stimulate more dopamine release, the person starts feeling better. Yet another vote for I bet there was too little dopamine. Anhedonia. Now, some insights about sort of the negativity, the negative affect of depression. And for this, we come to a whole circuit that has not been mentioned previously. First few decades of doing brain scanning, functional brain scanning on people, you throw somebody in a scanner and you do something interesting in front of them and you see which part of the brain activates, and woo, now you've learned something. And then you have the person just sit there doing nothing, and the brain is still like burbling along there. There's still all sorts of little rumbles of activation in the brain, even when the person isn't doing anything. Damn! Irritating noise, just nonsense variability in the system. So we have to learn how to subtract out the background noise to really get a sense of what's going on when you stimulate this or that area of the brain. And some years ago, a guy at WashU, St. Louis, Marcus Reichel, who's one of the gods in the field, sort of said, you know, maybe that stuff isn't just background noise that we have to get rid of. Maybe it's meaningful. And he pioneered what is now called a circuit, the default mode network, a set of connections between all these different parts of the brain that's just mumbling along there in the background. What's the default network about? Daydreaming, mind wandering, autobiographical reflection. How is this network taken over during depression so that you're daydreaming and your mind wandering and your autobiographical reflections are all negative? And what we see is a big role is played here by the amygdala and the anterior cingulate yet again. So we've got this picture here of like whatever circumstances are activating this too much and this too much, and as a result this is happening and this is happening. Can't the frontal cortex, can't the PFC jump in there and try to make things better? Can't it try to rein in these areas? Yeah, we're keeping the amygdala from doing something violent or something sexually inappropriate. Okay, now the PFC's got to keep the amygdala from generating sad thoughts all over the place. The PFC projections into all of these areas, these inhibitory projections, that the PFC is weakened during depression. So whatever bad stuff, the anhedonia, the rumination, it just keeps going on and on and on, because in this domain, the PFC, the right thing to do, the harder thing is to somehow get all of this stuff under control, and it's not working very well. And we will see why. Okay, so this now moves us to what's going on in the hours to days before. What about the hormones? First thing we start off with is the reproductive hormones, and focusing on the fact that there's a whopping big difference in the incidence of depression between women and men. Women have about twice the incidence of depression that men do. This has long been observed, and this has long been easily attacked with confounds. Oh, come on. Maybe it's not that women have more depressions. Men are less willing to admit to feeling down. Men are less willing to go see a mental health professional, and you got to control for that. And then another confound, men are more likely to self-medicate themselves to deal with their depressions. Men are more vulnerable to alcoholism, higher rates of alcoholism than women are, and there's lots of reasons to think that a lot of alcoholics are people who are self-medicating depression pretty ineffectually and in a way that will make things worse in the long run, but there's a male bias to that. Nonetheless, when you really do the good, careful studies that control for these factors, women have much higher rates of depression than men do. So, how come? In come all sorts of interpretations that has nothing to do with the biology of it. One of them is a very socio-cultural explanation. As we're going to see in a while, a major feature of psychological stress is lack of control. And in culture after culture, women traditionally have less control over their life choices than men do. Just ask any 9-year-old girl who's being married off to a 60-year-old guy kind of thing in that particular culture. So that interpretation, women traditionally have less control in their lives and thus they're more prone towards depression. We will see soon why that's the case. Then there's a cognitive interpretation, something that you would think is stereotypical, but actually comes through again and again in the studies. Women are more prone towards rumination than are men. When an upsetting interaction with a friend happens, things of that sort, women spend far more time, on the average, ruminating on this distressing outcome for a much longer period. Why did it happen? What does it mean for our friendship? How did we become friends in the first place? Whatever. Women are more prone towards rumination. And thus, a cognitive interpretation, this is a portal by which women have higher rates of depression. Maybe related to that, for the same social rejection, women ruminate much more on it afterward than men do. Okay, so those are a sociocultural and an affective cognitive model, all of that, but we already know that there's some relevant biology going on, because go back to those low-ranking baboons, and when those females are having their periods, they don't have the option to become more aggressive and irritable. They get socially withdrawn. They don't interact. They have that picture. We already know that towards the end of one's cycle, right around menstruation, right at that point, there's that massive drop in progesterone along with a drop of estrogen, and we know the relevance of that. What screams biology with the sex differences is that the times of life where there are dramatic fluctuations in estrogen and progesterone, and more importantly in the ratio of the two, is when you are most at risk for depression, when you are having your period, during menopause, and the single most dangerous period in life for somebody getting a major depression in the weeks to months after giving birth, post-parturition depression. And what do those all have in common? That massive drop of progesterone and estrogen, and all sorts of reasons to think that more extreme drops in some individuals are predisposing towards depression. How does this fit in? Every bit of neurochemistry we have been hearing about already with every one of these neurotransmitters is affected by the levels of estrogen and progesterone and the ratio of the two. and the rate at which the levels are dropping. And what we have is a very straightforward sort of pathway from dramatic changes in hormone levels during the reproductive cycle and changing vulnerability to depression. And we've got an endocrine feature to it. Yes, interesting sociocultural stuff, totally interesting cognitive stuff, but as soon as you're seeing a female baboon who shows a baboon's equivalent of depression right during the time that her progesterone levels are crashing, that's kind of screaming biology to me. And the fact that the most vulnerable times of life of a human female is related to those sorts of fluctuations, meaningful as well. Okay, next hormone system that we will spend 11 seconds on, thyroid hormone. Thyroid hormones keep your metabolism up. If you are hyperthyroid, your metabolic rate is way too high, your eyes bulge out, you waste away all of that. If you are hypothyroid, you become very sluggish and tired and you got brain fog and you put on a lot of weight. There's a lot of evidence to suggest that 10–15% of cases of depression are not caused by any of this world, but instead are caused by a thyroid problem of too little thyroid hormone. When you get someone who is hypothyroid, the symptom that screams through the most is the psychomotor retardation. You got no energy, getting out of bed is exhausting, and often that turns out to be an undiagnosed hypothyroid disorder going on in an outpost in the body psychiatry never used to think about. Then hormones, of course, what we get to now are glucocorticoids. You get somebody with major depression, and the majority of them show hypercortisolism, secretion of too much cortisol, the human glucocorticoid, and it takes a very interesting particular form. Here we have your daily circadian cycle of glucocorticoid levels. It goes up in the morning when you get up, because just getting out of bed is the most stressful thing in the day, and it crashes down at night, and that's your circadian. People with major depression, what they have is this circadian valley gets shallower. You get hypersecretion during this period. This period where, among other things, what excess glucocorticoids do is make sleep much less restorative. So that's one feature of it. The next feature is when you stress somebody. From the stress, they start secreting glucocorticoids, it's over with, they go back to normal. People who are depressed tend to have elevated levels in the absence of stress, that's this. And even more importantly, after the stressor ends, it takes longer to recover, to get back to baseline. And this takes us back to our concept of negative feedback signaling. The whole glucocorticoid system in the brain becomes resistant to a negative feedback signal. It's really hard for it to sense that it's all over with, go back to normal, and you just see the sustained secretion. Much more important for our purposes is if you expose somebody to really high levels of glucocorticoids for a long stretch of time, they have an increased risk of clinical depression. Pretty dramatically so in some cases. Where do you see this? There's this one disease called Cushing's disease, Cushing's syndrome. You got a tumor all sorts of unlikely places, like in your lungs, where the net result of that is you secrete excess glucocorticoids, massive excessive secretion of it, and you get all sorts of metabolic problems, immunological, all of that, and you get people falling into major depressions. Of course they're falling into major depressions. They have this totally sucky disease and a tumor and going on, all of that. So you have to control for the severity of the disease and other similar tumors in different places, and elevated levels of glucocorticoids in and of themselves predispose towards depression. The other realm where you see this is somebody who is given synthetic glucocorticoids, Corticosteroids. Somebody is put on steroids because they have an autoimmune disease, and you use these steroids to suppress their immune system. Somebody has had an organ transplant and you want to suppress the immune system so it doesn't reject the organ. So you put the person on, quote, high-dose steroids, of synthetic versions of glucocorticoids, hydrocortisone, dexamethasone, prednisone, a whole bunch of these. And what you see is if somebody is on high-dose glucocorticoids for a sustained period, they are at increased vulnerability to falling into a depression. Now, the strongest thing that suggests that glucocorticoids have something to do with it is consistently, when people get a first depressive episode that comes from out of nowhere, everything has been great for the previous 10 years or 60 years. The first one is almost always coming in the aftermath of a major stressor. Major stress increases the likelihood of falling into a depressive episode. And now you see something interesting. Okay, so stressful period, depressive episode, it ends, person recovers from it, and are they now more at risk for depression for the rest of their lives? Nah, have one stress-induced depressive episode, and that says nothing about your future vulnerability. Have two of them, and it doesn't say anything about your future vulnerability. And somewhere around 3, 4, 5 times that you have severe enough of a stressor to trigger a depressive episode, something changes. And the system starts cycling on its own, and the depressive episodes come independent of external triggers like stress. And it's at this transition that this person has now joined the ranks of someone likely to struggle with depression for the rest of their lives. A term is given for this. This guy in the business, Robert Post, years ago, took this great metaphor. Kindling, you kindle a flame, you get a whole bunch of little pieces of wood and you put them up and then they start a fire and they get the log going. Kindling as triggering a fire. And kindling is used metaphorically in neurology, talking about what are the events that kindle, that trigger an epileptic seizure. What has been borrowed here is the same concept. Repeated stress kindles the brain into now running on its own, getting depressive cycles all on its own. So, hormones involved. Now, let's look at longer term stuff. Let's look at structural changes in the brain, because you look at the brains of people with depression and the brains look different. The brains look different on brain scans. If you're looking at the size of areas of the brain, if you're looking at metabolic rates, the area that has been implicated the most over and over is the hippocampus. Major long-term depression, and there is atrophy of the hippocampus. Roughly approximating the scale you see of hippocampal atrophy with mild dementia, early stages of that, the hippocampus atrophies with major long-term depression. And people have known this for some decades. And of course, what that brings up is the issue of what if you get the person's depressions under control and they go away? Does the hippocampus come back? Literature is mixed. Early on, it looked as if there's no recovery at all. By now, the feeling is there's some recovery. What are the consequences of the hippocampal atrophy? That's where the cognitive changes are coming from. The memory problems, the cognitive distortions, where before you know it, you were distortively remembering that bad event as 10 times worse and 20 times more likely to reoccur and all of that. And the rumination, the hippocampus fueling some of that ruminative stuff, that's probably what's happening as a consequence of the hippocampal atrophy. Why does the hippocampus atrophy in major depression? And I spent about 20 years of my life obsessing over this, and elevated glucocorticoids and stress. Lots of glucocorticoids, and your synapses in your hippocampus become less excitable. The dendritic processes and axonal processes atrophy away. Neurons become more vulnerable to injury. They die if the glucocorticoid exposure is severe enough. You don't make as many new neurons in your adult brain, and all of this is built around molecular biology we already know about. Remember, glucocorticoids decrease excitability in the hippocampus, while the same glucocorticoids increase excitability in the amygdala. How come? Because of different receptor cofactors. This is where it's playing out. Chronic stress of major depression, and these are the mechanisms underlying why the hippocampus doesn't work as well. Other hotspots. You can guess the next thing, frontal cortex, because we've already seen it is not as capable of inhibiting the amygdala and the ACC and all these other sorts of places. It can't do the job of saying, no, stop thinking about the sad stuff. Get it out of your head. The PFC becomes less active in depression. What's going on structurally? The PFC, with major depression, months and years of, has gotten thinner. It's not loss of neurons, interestingly, but it's loss of glia, it's loss of processes, all of that. So you get thinning of it. That is the structural basis of the PFC isn't as good at getting the thoughts to stop, at getting you to do the harder thing and get up and get out of bed and all that kind of thing. Just before you panic, this literature, hippocampal atrophy, including almost certainly dead neurons, thinning of the PFC, are we talking about one depressive episode where you had to go for a dozen rounds of therapy and they tried some Prozac on you and it worked and you're okay now? Do you need to worry that you are damaging, shrinking your hippocampus and PFC under those conditions? Most of the evidence we have at this point is, nah, don't worry about it. This is someone who has struggled with frequent depressive episodes over decades of their life. That's where you see it happening. Okay, so we see all sorts of stuff happening now in terms of the brain, the neurochemistry, seconds before the circuitry, seconds before hormones over previous hours to days, structural changes over the course of weeks to months to years. All of that, we now know most of what biological psychiatrists know about for a living. About 2/3 of people with major depression, undiagnosed, never get any treatment. When they do, only about 2/3 of the time do the meds work. And when they work, about half the time people stop taking them because the side effects are too terrible. Nobody is curing depression simply by knowing about the circuitry or the hormones and the neurochemistry, all of that. It's at this point that we have to look at longer term factors. It's at this point that we bring in psychological features of depression. And of course, this false dichotomy, the neurochemistry of depression and the psychology of depression, they are completely intertwined, as we will see. And overwhelmingly, what it is about is psychological stress. Lion chases you, you secrete glucocorticoids. You have multi-system organ failure, you secrete glucocorticoids. You just feel like you're out of control in your life, and you secrete glucocorticoids. Psychological stress. What is it that makes psychological stress stressful? Where it's not an external reality, but it's something going on in your head. And a whole literature by now has shown what are the building blocks of psychological stress. And they come down to some totally logical, basic stuff here. Okay, take a volunteer and put them sitting next to put them in a room or what, and every now and then, unpredictably, they get a shock. Big surprise, their glucocorticoid levels go up, they secrete lots of glucocorticoids, you get a shock. Now, let's look at how the physical reality of the stressor is modified by psychological variables. First one, person is sitting there, they're getting the same shocks, same intensity, same everything, But 10 seconds before each shock, a little warning light comes on. And it becomes less stressful. Less glucocorticoids are secreted. There's less activation of the sympathetic nervous system, all of that. What is this about? Predictive information can be very protective, because what it allows you to do is know, here it comes, and I know how bad it's going to be. Here it comes. Let's prepare for it. And even more importantly, as soon as the stress or the shock stops, you know that you're safe until the little warning light comes on again. It allows you to relax. Without predictive information, any second you could be a half second away from the next shock. So, information, predictive information, can be protective. Only sometimes. Showing some elaborations here. Okay, so you're getting the shocks, all of that, and you get the warning light 10 seconds before, and it helps you plan your coping strategy, and it lets you know when you're finally safe and can relax, all of that. What if you do the same thing and you get the warning light 1 second before the shock? Has no effect. Not enough time to alter anything. Now, what if you get the warning light a minute before each shock? And you get something very different there. You get an outcome where you make things worse. Wait, I thought predictive information was good. 10 seconds to get your coping response all set and ready. Here it comes, here it comes. A minute, you're just sitting there and wallowing in the dread as the little Pac-Man is getting closer and closer to you, and the amygdala activates more. And if you have too long of a period of predictive information, it could make things worse. For example, like I suddenly pop into your life in an elfin manner and said, I've just gotten word from, fairy godmothers or whatever, that 3 years, 2 months, and 6.5 seconds from now, a comet is going to hit you. Whoa, predictive information, that's fantastic. 3 years, 6 months, and all of that to think about, counting my blessings and prepare for it. You get it far enough in advance, and it makes things worse. You get information about irrelevant stuff, and it makes things worse. In grad school, in the library, there was this table, the table from hell, where every day they would put out all of the new journals that had arrived that day, all the new science journals, and every evening you would go in there and walk around the table and have a panic attack because all this information that I'm never going to be able to absorb and couldn't understand anyway, and all of that, information that is overwhelming, information that is irrelevant, information that comes far in advance that saturates your ability to plan a coping response, those don't work. But within the right parameters, predictive information is very, very protective. Next, you're getting the shocks, you're getting the same shocks as here and here. It's absolutely out of your control, but they have suckered you into thinking that by pressing this lever, you make it less likely that there will be one of these random shocks. You think you have control. And totally independent of whether you actually do or not. In this circumstance, you don't. It's the same shocks, but a sense of control makes stressors less stressful. That's great. That doesn't work all the time as well. That only has certain domains. When does a sense of control, telling somebody they had control, even if they really didn't, but trying to boost up their sense of efficacy and autonomy, when is that helpful? When it's for something stressful that's mild or moderate. Because all you're doing there is biasing the person to think, whoa, it could have been so much worse if I hadn't had control. When is giving a false sense of control a disaster? When it is a major, major stressor. Because all you're biasing the person to think is, God, I had some control. The outcome should have been better. And we all know that in circumstances of horrible, tragic stressors, We try to minimize people's sense of control. Nobody could have stopped the car the way that little girl jumped out into the street. It wouldn't have mattered if you had gotten him to the doctor 3 months ago. They couldn't have done anything. A sense of control is most effective for mild to moderate stressors. Next, you get the shocks, and after each shock, depending on if you're a human or a lab rat or whatever, you can go run on a running wheel or gnaw on a bar of wood or go practice your cello if you have an outlet. That is protective. And then, last one, social support. If you got somebody's shoulder to lean on, and if it's a rat who's getting the shocks, it's having another rat, a familiar rat that it knows and likes, sitting right next to it that can sit and groom. And with us, you see somebody holding somebody's hand while they're having a scary medical procedure, a cardiac catheterization, and simply having someone there to hold their hand, less of a glucocorticoid response, less of a sympathetic response. And writ large, one of the things that makes for a world in which the ups and downs of the outside world winds up being catastrophically psychologically stressful is if you're doing it alone. Social support being hugely helpful there. Okay, so what we've set up here is a picture of psychological stress. And this brings us to what has been the most powerful model for how to put together the psychology of stress with the biology of it, all of that, a phenomenon called learned helplessness. You take someone and you condition them to feel helpless. There's some task. If they press the lever this number of times, they don't get a shock. And there's times they're all under control, and suddenly the lever stops working. And you try to do it twice as long, or you stand on your head and do it, and you come up with all these coping responses, and it doesn't work anymore. It doesn't work anymore. And early on, when you're saying, let's do it twice as much, it's anxiety. After a while, you give up even trying. That's a transition from anxiety to depression. No control, you got no predictability because it suddenly stopped working and nobody told me, and there's no alternative you can do, there's no outlet, and what learned helplessness is about is learning that you're in a situation where you have no control, no outlets, no predictability, no nothing, and when it's big enough, and when it's long enough, you suddenly get a cognitive distortion, as we went back to before. What is the rational thing to learn when you are going through a learned helplessness paradigm? A learned helplessness paradigm from you're getting shocks now and then, or you're a refugee, or they're dropping bombs on you, or any such thing. So learning to be helpless, writ experimental, or writ all of your life. What's going on in those circumstances? If you're really, really lucky when you come out the other end of it, you say, that was awful, that was terrible, I had no control, I had no outlets, it was so, so awful and all of that, but that's not the rest of my life. That was this one event with a wall built around it. That's the healthiest response you can get to it. And when the helplessness is severe enough, what you get is that wall demarcating, it breaks down, and you overgeneralize. And you turn it into inevitability about the future. That's where the cognitive distortion comes from. Not only was that awful and terrible, and that was really the case, but it will always be. I'm always destined to fail. I'm always destined to be rejected. That's the cognitive distortion. What learned helplessness does is take the sense of psychological stress and its consequences that is specific to this setting, and when it's severe enough, you pathologically overgeneralize it, distort that into a worldview. And a lot has been made about the fact that one of the great predictors about depression across all sorts of industrialized societies is the poorer you are, the more the likelihood of major depression. What is poverty about? Poverty is experiencing all of these things. Poverty is learning to be helpless. This is where that cognitive behavioral therapy comes in. That's sitting the person down and trying to take them through. Yes, yes, that was awful. That was legitimate. That was so sad, but it's not the rest of your life. And in fact, here we're going to do a little experiment. I want you tomorrow to do this, and you'll see you're not going to, it'll work. You're not going to fail again, or where you begin to cognitively take apart the distortion, cognitively do the work to turn that terrible thing is the rest of my life inevitably into, that was terrible, but that was that. That was all it was. Now, where this all begins to play out is we finally move to long-term experience. What does early life, adolescence, childhood have to do with depression? And what we see here is exactly the stuff you would expect to see. You see that you have an individual, you have a child, and what they're doing is not only learning about what's going on today, they're learning about what's the nature of the universe out there. Is this a benevolent world, or is it a mean one? Do I tend to have control over things? Do things come out from nowhere? Do I have friends? Do I have loving family? Do I have people that beat me at night when I come home? All these versions of that. And early childhood is when you could learn the lessons of learned helplessness with a vengeance. And what that begins to explain is one of the more reliable findings in the field. If you lose a parent to death when you were 10 years old or younger, for the rest of your life, for the decades and decades ahead, you have an increased vulnerability to major depression. How come? Because early in life, right around the time when you are most built around figuring out what the world is about, and you have the least frontal capacity to rationalize things away and put them in perspective and all of that, early in life, you were getting set up for the distortive overgeneralization of, I got no control, I got no predictability, and that's what it's going to be forever. Early life stress, and you put somebody closer to the edge of vulnerability for that for the rest of their lives. You see the exact same thing in primates and non-human primate studies with that maternal separation and vulnerability to monkey models of depression, monkey versions of depression throughout the rest of the life. You were setting somebody up for chronic overgeneralization, distortive belief that the hell that their childhood was is what it is inevitably going to be. You can see that played out quantitatively with our ACE scores, our adverse childhood experiences. Your ACE score is 0 to 10, and what we saw is the worse your luck, the higher your score, likelihood of antisocial behavior and unsafe sex and teen pregnancy, and among other things, increased likelihood of major depression throughout your entire life. So early on, you are learning about the world. Early on, you are also learning physiologically about it. What are the mechanisms for this? Take an individual and put them through severe learned helplessness, like refugee, for example, and you produce the profile of learned helplessness. You produce depression. You produce shortages of norepinephrine, serotonin, and dopamine. You produce excesses of glucocorticoids. You see disruption of the default mode network, all of that. What this does is it brings about exactly the profile and put a lab animal through its equivalent of a learned helplessness paradigm, and afterward, it has a shortage of serotonin and norepinephrine and dopamine, and it feels better when you give it Prozac, for example, and it has elevated glucocorticoids, and you see the same picture. What you're doing early in life with stress is adding an extra piece of it, because you don't just have your young brain then, you have your young brain going through a construction project and lots of early life stress. And what you will see is you make fewer dopamine neurons in our dopaminergic universe. Lots of early life stress, and you cause all sorts of epigenetic changes in the regulation of your stress response and regulation of, frontal cortical stuff. And early in life, major stress is setting down the building blocks in the neurochemical sense. You got a shortage of dopamine, you're depleted, and you are that much more vulnerable to, for the rest of your life, than to deciding there's no pleasure, there's no anticipation, and all of those, the neurobiology of what early life stress and loss and trauma and adversity do, the neurobiology that absolutely fits perfectly with the psychology of it. What about fetal life? Same punchline. There is a small literature showing that if your mother had a major depression during pregnancy, independent of what happens after, once you're born, independent of if you were growing up in a depressogenic household or if you're adopted away kind of thing, simply being a fetus in a womb of someone going through a major depression has some of these same effects. You make fewer dopamine neurons, you do epigenetic stuff that primes you for learned helplessness later on. It begins that early in life. Okay, so we've got two extremely different stories here. What is depression about? It's too little serotonin and too much glucocorticoids and screwy estrogen progesterone ratios and your hippocampus is atrophied and all that sort of thing. What is depression about? It is pathological loss of control, where you look at that and you decide, this is my destiny, this is inevitable. How do you put these pieces together? The neuroendoimmuno stuff we've had and the psychological picture of stress, psychological stress, being capable of generating something that looks like depression, that you learning to be helpless makes you vulnerable to depression for the rest of your life. How do you put the pieces together? Where we see the synthesis is genes. Where do genes come into this? And this is where we are going to get the integration between the hard-ass reductive biology and the psychological stuff and how they fit together perfectly. Where do genes fit in? Is there a genetic component to depression? Absolutely, it runs in families. All the adoption studies, even with all their confounds, show that emphatically. Yeah, there's a genetic component to depression. And of course, in our modern era, people have gone and done those genome-wide association surveys of looking at the entire genomes of 500,000 people with depression compared with 500,000 without, and let's look for hot spots in the genome where there's differences, and what that has mostly produced is the exact same picture we've gotten with all of these big survey ones. Dozens, hundred thousands of genes have been implicated, depending on how sensitive your search is, have been implicated in depression, and collectively they explain 10-15% of the variability. Our usual picture of lots and lots and lots of genes involved, and even collectively, if all you know about is the genes, and you should see just where we're heading right now, if all you know about is the genes and nothing else, it doesn't give you much predictive information. How about our other approach within the genetic realm of looking at candidate genes? Ooh, we know serotonin's involved, so let's look at every gene relevant to the serotonin system. Let's look at every gene relevant to progesterone, relevant to glucose. Let's go look at genes where we already know that there's a good chance they have something to do with this. And what you see is logical candidates pop up. Abnormal versions of mutations of in the gene that codes for an enzyme called tyrosine hydroxylase pops up. What does tyrosine hydroxylase do? That's the first enzyme you use in making dopamine or norepinephrine. Likewise, in another enzyme, tryptophan hydroxylase, what does it do? That does the first step in making serotonin for yourself. What else do you see? Other bits of genes popping in, genes related to the glucocorticoid system, genes related to the first hypothalamic hormone that starts the stress response, that's CRH, mutations in the CRH gene, mutations in the CRH receptor been implicated, mutations in the glucocorticoid receptor, mutations in the cofactors that bind to glucocorticoid receptors. Okay, all the usual suspects, and so far that's making sense. So no single one is explaining a ton. You sure should not expect that by now. If the genome-wide surveys gets you 1,000 candidates and collectively they don't explain much, even looking at the most plausible single gene isn't going to explain much either. Nonetheless, the logical suspects are at the top of the list popping up. Which brings us to the most important one of all. And this is a gene coding for what is called the serotonin reuptake pump. Back to the other side, the synapse, and you've released serotonin, and you either break it down or you reuptake it, and you recycle it into the presynaptic neuron, and what you see is there's a gene that codes for the serotonin reuptake pump, and it comes in different flavors that differ in their efficacy at removing serotonin from the synapse. People were figuring this out with rats, with monkeys, all of that, and you probably already remember, we have touched on this back when in the class. This is like the gold standard of gene-environment interaction. So, you're a human, and what are the consequences of having the bad version of the serotonin reuptake pump transporter gene, or the medium version, or the really great version of it, and what are the consequences? And say along with me, the answer is, it depends. It depends on what sort of environment. And we've got another version of the same graph again. Here we have people who have the good version of the gene, in between one heterozygotic version or homozygotically bad version. And what do you see? In the absence of major childhood stress, it doesn't matter which version you have. It's only as you see more and more major childhood stressors that the genetic vulnerability of these less than optimal versions come out screamingly clear. What's the effect of this gene type that you have on depression? And the answer is, it depends. How stressful was your childhood? What's the effects of a stressful childhood on your risk of depression? In part, it depends on which version. It's gene-environment interaction like crazy. This is an incredibly important landmark study. It came from this group at Duke, Avshalom Caspi. I think it's the most important paper in biological psychiatry in the last quarter century. It has been attacked in some sides in recent years, people claiming they can't replicate it. And my take of that literature is that these are people who are not very good with the genomic techniques for doing that, or these are people where what's counting as stress is getting diluted, their definition of depression is not classical. I think this finding holds. But whether it holds or not, what this mostly is this is our blueprint for how to think about this disease. We got the biological components, we've got the psychological components. What we have is the genetics of vulnerability. Have environmental sources of early life stress, early life trauma, early life teaching you to be helpless, and your genetic vulnerability comes screaming out at that point, and that's the interaction. And what is now known is when you look at the gene for the serotonin transporter, the reuptake pump, when you look at it, not only are there differences in the good, bad, worst version in the sequence, there's differences in how the promoter works. And what binds to the promoter? Glucocorticoids. In the absence of a lot of stress, this is irrelevant. Makes no difference. But as stress plays more and more of a role, the differences in the regulation come screaming out. And in lots of ways, then, you can define the genetics of depression is the genetics of being vulnerable to stress. of not being very good at being able to get off your rear and dust yourself off and go back to functioning is the genetics of vulnerability rather than inevitability. And it shows you the interactions between the biological vulnerability and the damn luck you've had and what sort of life you've sort of been dumped into interacts enormously. And in childhood, it interacts in ways that are setting a blueprint for how the rest of your life is going to be. Okay, so this brings us to the final piece here. Now that we see where the synthesis is between all the hard-nosed biology and the psychological stress, helplessness, and they interact in terms of the genetics of vulnerability and bringing in exactly the sorts of factors that should make sense at this point, we get to our final piece. What about the evolution of depression? It has a genetic component, so we know we have to ask that. What about the evolution of vulnerability to genetics? Very cool finding a few years ago showing that the Neanderthal genome happened to be very depression prone, and thus people who got the relevant genes there, that plays into some of this whole story. But bigger picture, so where is depression coming from evolutionarily? And when asking a question like that, the very first thing you have to ask is, are we alone? Are we looking at something that is specific to humans? And the answer is no, absolutely not. You do those Harlow infant monkey isolation type things, and you make that monkey learn helplessness as an adult. It shows a monkey's version of major depression. You can induce it experimentally. Much more importantly, you go look at primates in the wild, and they get something that is not a model of depressive-like behavior. They get major depression after absolutely logical times, like your loved one, your mother has died, when your infant has died. Every person who studies baboons for enough decades always sees eventually the same thing. A female who gives birth and something goes wrong, the kid is sick and dies a few days later, and the mother carries around the corpse of that baby for weeks afterward until it is mummified. During that period, she socially interacts less. She stays back by the sleeping trees during the day. She eats less. All of that, she falls into the depression of losing her child. And again, that is not a depressive-like behavior in baboons. That's depression. And when you study primates with something like that, it's the same neurobiology. So, if we're asking how did depression evolve, we're asking that not just for us, but other species as well. So, right off the bat, there's the possibility that we evolved genes for depression because they were great, they were beneficial. Maybe a partial version does great stuff, or depression itself can be great for you. Yeah. One version is people saying, oh, it's a very effective cry for help. It doesn't work. People who are depressed are not very good at eliciting help. People run for the mountains to get away from depressed people in every culture out there. It is not an effective help eliciting mechanism when that has been what you've been like for years on end. Oh, maybe it boosts creativity. There's like a little bit of evidence for that, but that sure is not enough to explain anything, and especially when we're explaining the same genetics in some other primate. Okay, so is there a downside to depression? Major league in terms of Darwinian fitness. People with major depression, on the average, leave fewer copies of their genes. They have a shortened life expectancy. A big hot topic that's been going on recently at UCSF is showing the ways in which depression increases the risk of cardiovascular disease, of diabetes. Slowly is emerging literature that I was betting on in the 80s and was beginning to do some work on, which is chronic depression increasing the likelihood of dementia. And there's ways in which stress and depression interact with Alzheimer's disease that are, okay, so it's terrible. It has all sorts of ways in which there's downsides to it, and thus we're left with this final question. How did we evolve the genes that would make 15% of us have shortened life expectancies and heart disease and accelerated dementia, all of that? What possible reason is there for us having evolved this genetics of vulnerability? And I think the answer is that that's the wrong question to ask. When you look at the nature of life, and we will all want to attain things that will not happen, we are all destined to lose some of our loved ones, we all know what our eventual fate is, we all know all of that. When you look at all of that, what you see is depression is a disease where you have a pathological inability to rationalize away reality. And in that context, probably the more valid question than asking, why did we evolve so 15% of us get this disease? The much more valid question is, how did we evolve so that 85% of us are resilient enough not to get this disease? Okay, so that is our tour of depression. And please, please, please look at the notes at the end of the handout. Yeah, it's really pertinent whether or not your brain is emergent, and like this topic is super pertinent to lots and lots of you there, so please pay attention to what it says at the end.